Good day and welcome to the Young Adult and Pediatric Blood Cancer Updates and Advances conference call. Today's conference is being recorded. At this time, I would like to turn the conference over to Jennifer Gillette. Please go ahead.
Thank you, Ron. Yes, my name is Jennifer Gillette, and I am the staff social worker at the National Bone Marrow Transplant Link. I'd like to welcome everyone here joining us on the call today. This month's program will focus on advancements in young adult and pediatric blood cancer. A special thank you to our sponsors for today's program, the Leukemia and Lymphoma Society, Insight Corporation, Pharmacyclics and Janssen, and Omeros Corporation. And of course, we always thank our LINK partners. Today's outline will have a few minutes of introduction for those who are not familiar with the National Bone Marrow Transplant Link. And then we will have about 20 minutes of presentation from Dr. Luisa Sulis. And then I myself will be giving some tips on coping for both children and young adults. And then we'll open up the floor to some questions, and some of those will be live and some will be the pre-submitted ones. And then, of course, we'll wrap up with a few minutes at the end with some resources. So for those who may not be familiar with the link, our mission is dedicated to helping individuals and their families from diagnosis through survivorship. We provide resources, support, and education. Some of the resources we provide to help families navigate their transplant journey are webinars, podcasts, blogs, lunch and learn calls like the ones you're on today, and we have a variety of topics such as chronic graft versus host disease, disease-specific information, caregiving, coping, treatment options, survivorship, and more. We also have an active Facebook page with daily inspiration and relevant tips for survivorship. We have our peer support mentor program, which is for caregivers, donors, patients. We have our second birthdays recognition program. And we also have books, referrals, and emotional support from a licensed social worker. So if you need extra support, please feel free to reach out to us. Before we begin today's program, I would like to review just a couple housekeeping items to maximize the experience of all on the call. Please be mindful of being concise with questions so that we may answer as many as possible. And also, please know that the information provided in this program is meant to stimulate conversation with your own healthcare provider and is not meant to replace your individualized medical plan. So now, on to the educational part of our program. We are so thankful to have our first speaker here with us today, Dr. Luisa Sulis. She is the Chief Pediatric of Hematologic Malignancy Services at Memorial Sloan Kettering. She brings over 28 years of experience working in the medical field, and her research focuses on acute leukemia resistant to conventional therapies. Her hope is to use the advances made in the understanding of the biology of leukemia and how patients respond to therapy to improve the effectiveness of children's cancer treatment. She and her colleagues developed studies for children with newly diagnosed and relapsed T-cell acute lymphoblastimia. They also study how to prevent a relapse of AML after a stem cell transplant. So without further ado, thank you so much for joining us today, Dr. Sulis.
Thank you, Jennifer, and thank you to the organizers for inviting me. This is an honor to speak at this, for me to speak at this event, and particularly a privilege and an honor knowing that the audience is composed of patients and families who have been directly or indirectly touched by the diagnosis such as hematologic malignancy. As you said, I am a pediatric hematologist oncologist, and we care for children and young adults with diseases that arise from, in general, that blood system. So blood cells, white cells, red cells, platelets, as well as lymph nodes and other organs that participate in the making of the blood. So it is somewhat broad variety of diseases, and some of them are much more frequent in children than in adults, but there is a good overlap between adult and pediatrics. And in fact, I would say pediatric oncologists are more and more actually working and collaborating with the adult colleagues, because I would say that the recent advances in the understanding of the biology of these disorders have also shown us that there is an evolution, there is a continuum in the development of a disease, and many diseases may actually originate very, very early in life and remain kind of dormant or latent until later on in life. As many of the people in the audience would probably know, many times when you go to your physicians following a diagnosis, the physician may say this disease is very rare in the adult population, it's more common in pediatrics, or the opposite, this disease is rare in pediatrics, more common in adults. And in part because of that we also try to collaborate as much as possible. To give you an example, for us, for pediatricians, acute lymphoblastic leukemia is by far the most common hematologic malignancy, and with about 3,000 children diagnosed every year in the United States. On the opposite side, acute lymphoblastic leukemia is actually quite a rare disease for the adult oncologist, and they diagnose the same number of patients, about 3,000 adults per year. So the number of people diagnosed with acute lymphoblastic leukemia is actually the same in the United States per year between adult and pediatrics, but for us it's very, very common, and for them is quite rare. What does this mean? It means that the adult oncology have reached out to the pediatric world to understand how we treat them and how and why ALL remains a very difficult disease to treat in the adult population, usually needing a bone marrow transplantation to achieve cure, while in children, in pediatrics, 85-90% of children are cured without the use of such an intensive intervention. And this level of collaboration with the adults have allowed particularly to advance outcome in a specific subset of patients, the young adults, for whom the definition of really who they belong to, are they children, are they adults, has always been a little bit blurred. And so the adults have significantly advanced the outcome of young adults by actually reaching out to us and borrowing the regimens and the novelties introduced into pediatric regimens. On the other side, for example, AML is acute myeloid leukemia is rare in children, only 500, 600, 700 children diagnosed every year in the United States, and extremely frequent in the adult population, particularly in the elderly group. And we have learned a lot from the adult population, from the adult physicians. One of the things we have learned the most, starting really with AML, is actually the importance of making a very accurate diagnosis. And I'd like to spend a little bit more time on this because I think this is something that is important for all subtypes of hematologic malignancies, leukemias and lymphomas, but really important for the care of every patient with hematologic disorder and every patient with a disease. If anyone has experienced the distress and the difficulties of not being given a clear diagnosis, you can understand and imagine how without a clear diagnosis there cannot be a clear therapy, and therefore there cannot even be a defined or understood expectation of outcome. And the reason why I bring up the importance of the accurate diagnosis is because, fortunately, over the past decade, the progress in diagnostic tools which have leveraged on the technological progress have really changed the way physicians think of the disease, the way physicians interpret results, and the way physicians tailor therapies. So that today saying your diagnosis is ALL, acute lymphoblastic leukemia, your diagnosis is acute myeloid leukemia, your diagnosis is chronic myeloid leukemia or Hodgkin lymphoma or non-Hodgkin lymphoma, has a little bit more decreased meaning than you used to have 10 years ago. If everyone in the audience has been recently diagnosed in the past 5, 7, 8 years, you probably recall, if it is possible to recall anything from the first few weeks since the diagnosis, which is the most kind of chaotic and confusing time, but the physicians come back at different times saying, okay, the diagnosis is this, I'll come back with you with more results. And a week later, they'll come back to you with cytogenetic results, and then 10 days later with FISH results, and then 2 weeks later with genetics result. So that to actually conclude a diagnosis and being satisfied with the understanding of your disease requires some time. This on one side can be frustrating and sometimes can even delay a little bit the intervention or lead to a change in therapeutic intervention. But it is actually to be taken as a great fortune and great value because it tells you that your disease will be better understood, will be better attacked, and this will lead to a better outcome. And most importantly, the physician is actually really thinking of your hematologic malignancy in your therapy in a very, very personal way. And so I encourage everyone on the call to actually engage in conversation with your physicians about this and try also to understand as much as possible about the details of your disease, because as things evolve, you'll be able to also follow better the progress and that will lead to hopefully the cure of these diseases. There are, to give you some example, for example, if I remember when I first started more than 15 years ago in my profession, the report of a diagnosis was just a few lines long, and even the classification of diseases was just few categories. And today is an evolving process, and that every few years needs to be updated to incorporate new findings about each diagnosis. Many of you have probably, at the time, once the diagnosis has been finalized, have been also told about specific genetic characteristics of your diseases. And, for example, if it is ALL, maybe some of you have been diagnosed with Philadelphia positive ALL or with MLL rearranged ALL or 1221 translocations and other very specific names of the disease, PH-like, BALL, ETP-TALL, and so on. Or if anyone has been diagnosed with AML, you probably have been, some of you may have mentioned FLT3 positive AML, IDH1, IDH2 AML, things that really don't make any sense, don't mean anything to you. But I'm sure your physician has also explained why it is important to call the disease in this way, and what it means from a prognostic point of view and what it means from a therapeutic point of view. Attached to any of this clarification, a specification of a disease, there is a prognosis, which sometimes is better prognosis, sometimes is worse prognosis, and many times there is a therapy that is attached to it, or the option of a therapy should the disease come back. In the last decade, really the technological advances in reading the genetic code of the disease has incredibly broadened our view of leukemias and lymphomas. And now we understand much better. It's still a very limited understanding because cancer is a very, very complex disease. But now we can understand a little bit better why this disease responded so easily and so fast, and why instead this disease took several trials and frequently even a transplant to be cured. And the detection of these specific abnormalities at the level of the genes of the cancer have allowed companies, pharmaceutical companies and biotechnological companies to design really in the laboratory with the help of softwares, new molecules, new drugs that need to fit and to attack specific vulnerabilities, Achilles heels of that specific genetic mistake of that specific disease. And it's designed to, at least in the laboratory, to perfectly match with that gene. Now, we all know the laboratory is not real life, and so sometimes things work really perfectly and really, really well, as in the case of chronic myeloid leukemia, where really the outcome of patients dramatically changed. Where everyone used to need a transplant 30 years ago, and today everyone takes a pill at night or twice a day, and never needs a central line, never needs a transplant, and that's it. But sometimes things don't work perfectly and need some refinement. So it's always an ongoing process. But the advancement and the change that happened in the last decade is such a promising, I would say, revolution that we all witnessed that makes me think, and all of us think, that the future will be even better. So many of these diseases many of these therapies that have very strange and difficult to remember names are really things that have been added to regular conventional chemotherapy to improve outcome. Sometimes I even think that there will be one day where chemotherapy will look and will be referred to almost like a barbarian way of treating patients, because it's something that, as many of you know, does not really specifically attack the cancer, but it attacks also our normal cells, and that's why patients don't feel well, why they lose the hair, and so. And our hope is that one day we're not going to be using them anymore, and that we'll be instead closer to the treatment of CML, where one or two different medications taken by mouth are sufficient to control disease. So the importance again of an accurate diagnosis that can lead to an accurate treatment, and hopefully to a decrease in toxicity. The second big revolution that we have witnessed in the past decade, and I really think will dominate the future of therapy of hematologic malignancies, is immunotherapy. It's been decades, or even more, that since physicians have tried to understand why our body does not recognize a cancer cell as foreign, as abnormal, and why doesn't it kill it? We all have we all know that since our young age, our body is able to recognize germs. Our body is able to fight bacteria, to fight viruses, and kill them. Yes, we have antibiotics and antiviral medications, but even without them, in a healthy person, germs and bacteria and viruses can be defeated even without antibiotics. Certainly it takes longer. Certainly the disease and the illness is much more intense and stronger, but they can be defeated. But still, instead, our immune system, our defense system cannot necessarily recognize the cancer cell and destroy it once it's already the cancer is already developed. And so a lot of attention, a lot of effort, a lot of research, and much more now, and also much more funding, thankfully, has been put into how can we, now that we understand better the immune system, how can we use the immune system and help the immune system to better recognize a cell that is not normal, that is cancerous, and try to destroy it. And if there is anyone in the audience who has been diagnosed with acute lymphoblastic leukemia, and especially if there is anyone who has unfortunately experienced a recurrence of lymphoblastic leukemia, has heard about immunotherapy for ALL. Particularly several new drugs like blinatumomab, inotuzumab, and certainly CAR T cells. So what are they? These are specific. These are either antibody-based therapies or cellular-based therapies. So both the antibody-based therapy and the cellular-based therapy are interventions and approaches that use what we know of the immune system that the immune system uses to fight foreign molecules, foreign proteins, and foreign, for example, germs. And so either the companies have designed antibodies that specifically can recognize the leukemia cells, specific protein in the leukemia cell, and kill it in the same way that after our body meets a bacterium, a germ, the body responds in making an antibody that will recognize that germ specifically and kill it. Or the laboratory has designed and engineered, changed and engineered our own immune cells, like T cells, in a way that they are better at recognize the cancer cells, so that when these T cells are reinfused in the patient's body, can specifically and selectively attack that leukemia cells. The process of making these medications and these antibodies and these cellular therapies is very laborious and takes very, very long time. But I think this is because we are at the beginning of this, and it's certainly much faster than it used to be, for example, even a few years ago. And it's been sort of a very interesting journey for all of us to learn about them and learn how they work. Also because they have a completely different set of adverse effects of toxicity that some of them were somewhat expected, but many were not. And so there's been really an incredible amount of time and used to really get together, all of us, physicians and nurses and families, and both in the adult and pediatric world, to really try to understand as much as possible and try to harmonize the intervention that we use in order to understand better also the responses to our intervention. And the advent of immunotherapies have completely really changed the way we treat leukemias and the way also we treat lymphomas. For example, if there is anyone in the audience who has used was Hodgkin or non-Hodgkin lymphoma, you probably have used rituximab, you probably have used brentuximab, which are all antibodies, or you've probably been treated with other immunotherapies such as nivolumab or pembrolizumab. These are all part of this incredible revolution in the understanding of the immune system and in the ability to use the immune system to fight disease. I already in children and in adults, certainly in talking with my adult colleagues, I can say both in adult and pediatrics, in lymphomas and in leukemias, both AML and ALL, immunotherapies are becoming more and more upfront. And so rather than being utilized only for patients who have the most resistant disease, because we also see that not only they are very effective, but they are also somewhat safer in terms of toxicities, we are now trying to incorporate them earlier on in therapy, not only to improve outcome, but also to decrease the short-term and long-term toxicities of chemotherapy. As you can imagine, short-term toxicity is certainly a major concern for both adults and children, but long-term toxicities are a significant concern for children and young adults. And so there is always, every time a new therapy and a new regimen is designed, two things are always kept in mind. How can we improve survival? How can we decrease toxicities? And I think the ability to now utilize these new tools, genetically targeted therapies and immunotherapies have even more given us the option to really refine, modify, improve the regimens that we use. And just as a last remark, I remember when I was initially starting work as an attending, all the new regimens, all the new protocols that we were using were all based on intensification of chemotherapy. Increase the dose, increase the frequency. Every schedule was becoming more and more intense and tight. Until we reach the point where you can't add anything anymore, or the risk-benefit ratio will be not in favor of the patient and the outcome. And so there we've reached the plateau, we touched the ceiling, and now with the advent of these new therapies, we are actually now going back and reviewing all this regimen and this protocol, trying to decrease the intensity of chemotherapy and substitute those, increase those and more intense schedule with this new medication. So for everyone who has been recently diagnosed, it's obviously you're already probably receiving therapies that are certainly much more advanced than people who have been treated years ago. And for patients who are unfortunately experiencing a recurrence, well, there is way more, many more things that we can do now to help with treating and curing recurrences. So we're not talking only about giving a treatment. We're not talking about prolonging life. We're really talking about the real possibility of patients being cured. And I think I probably went over my time, Jennifer. I can stop here if.
Well, we are thankful for everything that you are sharing, and I'm sure we're going to have some questions too. But I'm going to give a little bit about coping before we go there. And again, I just thank you, Dr. Sulis, bringing all your expertise and being here to educate us all today. So thank you so much. And as the staff social worker at the LINK, I will be speaking today. I come to this just so you know what or how I bring the information I bring. I come with over 25 years of oncology social work experience, my years of interacting with patients in both inpatient, outpatient, and private practice settings, and as someone who has experienced cancer multiple times, in my own family. And so I am bringing to you all these tips that I have heard from the greats over the years, and I hope that at least one of them is helpful to you today. So as far as helping kids cope with cancer, the first tip I'm going to give you is, parents, make sure you're taking care of yourself, realizing that you are the captain of this healthcare team. And by taking care of yourself is first making sure that you find ways to cope with your emotions. Those wonderful kiddos really can absorb the emotions of what's happening in us in addition to their own emotions. And so if you take care of yourself, you're going to, it's that typical airplane saying of put the mask on yourself. And so I encourage you to find ways to deal with your own stress with everything that's going on. Number 2 is realizing what an important member of the team you are. No one on this planet knows your child like you, and you will be the first to notice any changes in behavior or anything that could be relevant to how your child is treated. So it's really important that you report those observations to your healthcare team, because something might just seem like a bad day to someone else, but you know with your own child what is usual and what's not. So keep those observation glasses on. Realize that the siblings on this journey need some extra TLC too. There can be extra frustration sometimes, feeling like the child that's a patient is getting all the attention. So if there's ways to have a little extra one-on-one time here and there with those siblings or extended family members that can give them extra love, that's an important thing to do. Another thing is being honest and age-appropriate in your communication with your kids. Kids are magical thinkers and can fill in gaps when they're missing information. Keep in mind with this magical thinking, sometimes those gaps they fill are with worse information than what is actually the truth. So being honest but age-appropriate is a good thing. They need to know also that nothing they did has caused this, and nothing they do changes their medical piece here. Like some kids might feel like, oh, well, I wasn't listening, or maybe that's why my blood counts are bad. And, so it's important that we bring what is truth to them. And, with kids, keeping in mind, too, that like play techniques, books, or art often can be great ways to explain things to them. Be positive, but foster trust. Because if they find out that you're not being real with them, keep in mind you are working on developing a trusting relationship with your child all their lifespan, and you don't want them to have mistrust with you. Number 5 is try to keep some routines. It keeps a sense of normalcy and helps kids stay grounded. And this goes for the siblings, too. If there's some sports or different things those kids love, and there's a way that they can still make it, like with friends taking them to practices or things like that, try to make that happen. This may involve asking others, but it's certainly worth it. And I think that's one thing we all learn is it takes a village when you go through this. You can't do it by yourself. Another thing for kids is knowing your kids' love language and what comforts them when they are nervous. For those of you who might not be familiar with love languages, basically there's some thought that we all experience love in primary ways. Some might be touch, like maybe hugs or kisses or cuddles. Others might be gifts. Another love language is quality time. Another is acts of service. And another is words of affirmation. Like if you have a child that is really feels loved by those words of affirmation, telling them how strong you think they are, how proud you are, and also knowing what is distracting and calming to them. Everyone might experience that differently. Some people want to be held, some people don't. Or especially when it comes to teenagers, they might want to be more independent perhaps, but then there's others like my middle son, if I bring him breakfast in bed, he thinks I'm the bomb. So I encourage you to find out what works best for your child. Number 7, learn how to communicate effectively with each other and set times aside often to check in. Make sure we're answering questions and encouraging them to express themselves. Try to give choices where you can and give them a sense of control. For example, with kids, some medicines we might be able to wrap it in a fruit roll-up if it's disgusting. And you could ask them, do you want it with the fruit roll-up or without today? Number 9, try to make things fun when you can. For example, hydration can be a really important thing with kids going through cancer treatment. And there's little apps and things you can download that, like there's one called Plant Nanny, where the child is able to put in how much water they've been drinking, and if they're drinking good, it makes their plant grow. And it's just a cute, interactive game for the kids. Number 10, keep them posted on treatments and things that can change as a result. I know there's always going to be a balance of you don't want a child to stress for long periods of time about something, but again, that honesty message is important. Find ways to keep them connected with friends. For example, some kids with the video games and things nowadays, I think we've learned with COVID how to do things more remotely, and that can really benefit the kids going through this, because even if they're dealing with immune issues, we want them to still feel connected, as well as with family and everything too. It might be Skype or FaceTime. Maybe the Messenger app, the Kids Messenger has games on it, and you can talk and play games at the same time with the kids. Or there's another really cool app I've even used in my own counseling during COVID called Caribou, where you can read and color and do other activities with children while talking with them at the same time. And that might just be ways for grandparents or extended family to stay in contact too. Find ways for them to connect with other kids who have cancer and that understand their experience. The fact is, nobody on this earth knows more than people that are going through it, what this is really like. And so there can decrease the sense of isolation when they feel like they know people that are going through the same thing. Consider support from the social workers, therapists, pastors, etc. We all need extra help now and then, and don't be shy about it. Also, being open with friends on what is helpful. I know one of my son's friends has surgery every 6 months based for a health issue he has, and his class has gotten really creative about like even little drive-by parades and different things just to show him support when he's getting ready for one of those surgeries. Another thing you can do is find ways to help them physically, emotionally, and verbally calm, distract, vent, because this is just a very stressful situation for everybody. So also setting realistic expectations, but still encouraging your child to do their best. We don't want them to feel like all limits are removed, because keep in mind with kids, if we are too rigid, we make them withdraw. But if we take away all sets of limits, then they feel like they're lost or they're falling. So try to set some still realistic expectations, like it's still not okay to be talking back or be mean to your sisters. And we can certainly empathize and say, I understand why you might feel frustrated, but there's still appropriate ways to handle that frustration. And then, of course, finding ways to relax. This is an exhausting journey that affects body, mind, and spirit, and so it's important that you tend to all parts of that within yourself and your child. And now I'm going to kind of change the focus for a minute and just spend a couple of minutes before I close talking about young adults and teens, because I know that there is a unique set of needs in this area. I encourage you that are within the young adult community to encourage you to try to connect with the community, such as Stupid Cancer or Elephants in Tea, because they really understand the age-specific time that you're in and the kind of needs you have. You know, having someone in a support group that's 20 versus someone that's 80, there's a different set of life circumstances typically, And although each can still contribute to each other, it just is a different time. There's also a great app, the GRYT app, which is like support in your pocket. And just in case anyone's trying to take any notes with this, I will send the coping notes in the email with the recording of this Lunch and Learn as well. Liz Strong is also a great support for young adults with cancer, especially since if you think about when you're in this particular stage, there's major life changes. It's a time of transition in so many ways. Like you might be stepping back and being more independent, going to college, but then maybe you're diagnosed there and you have to get thrown back into living with your parents. Your finances can be strained because you're not as established in your career typically. You've started building a life and often have that change. For example, maybe that first apartment or not being able to work. There's a natural time of social transitioning that happens in those young adult years too. So core groups might be going away to school, and so the deeper friendships might be changing. The psychosocial distress is usually higher as they also haven't had as much chance to build life skills and coping skills for some of these hard things in life. And there's challenges getting back into school, body image issues, perhaps added stress to finding help with young children, feeling isolated from responses from friends that maybe they can't relate or just are kind of wrapped up in their own thing, insurance issues, and then physical abilities can change life paths, which can be a really hard thing to cope with. Over half the AYA population feels that their needs aren't really met. So I really encourage you to try to reach out to some of those resources like Stupid Cancer. And then we also had a great Lunch and Learn specifically about young adult cancers, which you can check out on our website. And one of our doctors, Dr. Connolly, he used to be on our board, gave us some great tips too. He had said, ask your AYA center about programs or particular people that specialize with your population, and ask for that psychological support. You can ask for face-to-face meetings too. You can reach out to places like the LINK or Immerman's Angels or other organizations to get a mentor. That is to talk to people who have already gone through it, understand it, and are doing well, and they can answer questions and just encourage you. You can blog and communicate to family and friends or connect via social media. You can look for easier ways to communicate with your healthcare team too. Perhaps there might be direct messaging or through an electronic file. And you can tell your providers who you want involved in your care. Once you're over the age of 18, you certainly get to say who is on that team. You can find ways to discuss your experiences with peers and family, maybe even invite a friend to treatment to help. And also just keep in mind to set up realistic expectations again here. Often people 6 months out or more try to rush into their old lifestyles, and it can really set them up for failure because it's best to start slow and steady. For example, like if you want to go back to college, maybe start with online or going back part-time and seeing how you do, because cancer, it can definitely affect your strength. And then be aware that there's scholarships available to those in the AYA community. And remember that survivorship is a whole life thing. And so keep in touch with your team and your supports, and that will help you get through. But on that note, those are some coping tips for those of you going through this. I hope one or two of them are helpful to you. But for now, Ron, if you could please tell our callers how they can ask a question.
Thank you. Ladies and gentlemen, if you'd like to ask a question, please signal by pressing star 1 on your telephone keypad. If you're using a speakerphone, please make sure your mute function is turned off to allow your signal to reach our equipment. A voice prompt on the phone line will indicate when your line is open. Please state your name before posing your question. Again, press star 1 to ask a question. We'll pause for just a moment to allow everyone an opportunity to signal for questions.
Thanks, Ron. And while we're waiting for people to be able to do that. Dr. Sulis, I know we received one question, or Sulis, I'm sorry. We received one question about COVID vaccines and perhaps being a false sense of security with cancer patients. Could you speak a little bit about the COVID vaccine and whether they find it's really working in this population?
Sure. I think the COVID infection and COVID vaccine is always it's a constant point of conversation among physicians and families, and certainly has changed a lot in the way we live and practice. So I think everyone has to understand and accept that, unfortunately, because of how fast things happened, how fast the pandemic arrived, how fast the vaccine was offered, that we haven't accumulated enough data to better understand what is the level of protection that the COVID vaccine gives, and what are the differences among healthy patients versus patients who are receiving chemotherapy, and even within the group of patients who receive chemotherapy, is there a difference between patients with hematologic malignancy, patients with brain tumors or solid tumors, and so on? And so we're just really learning this. However, and I'm sure everyone experienced this, the last year has been really, really incredibly difficult to manage for all the different subspecialties, and particularly for there were a lot of concerns for patients who are immunocompromised. Now, I work at a cancer center, and so I was really only exposed to patients who have a cancer diagnosis. I think we learned a couple of things, in particular for this population. One, this is a population who have learned from the beginning, from the time of diagnosis, to be very, very cautious, because of the higher risk of infection. And that cautiousness, I think, has also helped our patients because the rate of infections have probably been a little bit lower than you would have expected. Now, regardless, because they are at risk, not only of contracting an infection, but also becoming sicker, more ill with an infection, we have absolutely welcomed the arrival of a vaccine, and admitting that in certain circumstances we did not have and we don't have all the data available in the way we would like and in the way that we are used to every time make a recommendation, we still feel that it is if there is a likelihood, which seems that there is, that this vaccine will certainly protect from getting a pretty severe infection, we should offer to the patients. And so we absolutely recommend it to all of our patients. Now, I'm sure people who are receiving chemotherapy in the audience would think, well, my physicians have always told me that the chemotherapy decreases my immune function. And so how can I be able to mount a response to the COVID vaccines? And that's a very, very good question, a very rational question. However, there is always a little bit of immune system and immune function that is left there, and we're clearly leveraging on whatever is left in the immune function for your body to mount a response to vaccine and hopefully protect from an infection or from a serious illness after an infection. So we are generally recommending this, and this, I think, is a consensus among in the field of oncology, but with the understanding and with the clear message that a COVID vaccine does not mean that you can lower your guard. Absolutely not, in the sense that we are still in the middle of this battle. We have not won yet, and so we always tell patients use masks as directed when you are in closed space or you're in a group. ask for the vaccine whenever your treating physician recommends. But we don't have any reason to think that it would be harmful. And so our recommendation within the field is actually to proceed with the vaccination while maintaining being always very, very careful.
Thank you so much. Ron, is there anyone in queue?
Once again, ladies and gentlemen, if you'd like to ask a question, please press the star followed by the 1. And if you're using a speakerphone, please ensure you lift the handset.
And while we're waiting there... Oh, I'm sorry. Go ahead.
Go ahead. I was just going to say there are no questions on the phone lines at this time. Please continue.
Okay. Well, please let me know if anyone comes in the queue, but we do have some pre-submitted questions, and so I will continue to ask those to the doctor until we hear any live questions. One, doctor, was about prevention. Someone was asking us about, is there anything that we know of that is really causing blood cancers?
Yeah. So prevention is probably one of the most difficult fields, but it's always one of the missions of every institution, every cancer center, every oncologic division. Epidemiology studies are always ongoing, but differently from the progress that I mentioned before about understanding the disease and improving therapy. The progress in actually understanding what are the causes of the disease and what are interventions to prevent have not progressed as much. I'm sure you can understand that if we do not know why a disease happened, what specific agent caused the disease, we cannot do much for preventing. So, of course, certain things we know. We know that smoking is very closely related to lung cancer. We know that human papilloma infections are closely related to cervical cancer in women. We know that HIV infection can lead to lymphomas. We know that exposure to radiation can lead to leukemias, and exposure to certain specific chemical agents can cause AML, and that has been. We know that from epidemiological studies that have been done in specific settings for people that worked in specific areas of the world and were exposed to known agents. But other than that, particularly around food, which I know it's always been a topic of discussion, and particularly around food, there has really not been any specific either particular type of food, a particular agent used to grow it or to clean it that can be linked to the development of that. What we have, and so because we don't know that, the prevention is also difficult. What we have learned in the last decade that has really changed a lot in our view of disease is actually the understanding that many more people, including many more children that we would have ever imagined, are actually born with a predisposition to develop a disease. We always, why did I get this cancer? Why did my son or daughter get this cancer? Is one of the first questions that families always ask, and we were always had to answer, we do not know, and this is probably just really bad luck. Today, the answer has changed in the sense that we can say most likely we will not know, and we will never know. However, we do need to check to see if by any chance you or your child have born with increased risk to develop this disease. And now we have the tools to do that. Physicians have and families have different opinions on how to use it and when to use it. But I think it is important to know that this is real. There are a percentage of patients who are born with a predisposition, and something can be learned. Can it be prevented? No, certainly not for the patient because he has already experienced a disease. But the potential occurrence of additional malignancies can be, if not prevented, it can be probably diagnosed a little bit earlier. And certainly, if one of the patients is found to have a predisposition, that information can be useful for other members of the family or is of the family of the person diagnosed. So again, this is something that absolutely needs to be discussed within a family and within and with a treating physician. And each one of us have a very different opinion, but people should know that there is this option.
Okay, thank you.
Pardon the interruption, Ms. Gillette?
Yes.
I do have a few questions that have come through on the phone lines. May I continue?
Absolutely, thank you.
We'll take the first question. Please go ahead.
Hello, my name is Mary. I'm a caregiver for a 49-year-old male with follicular lymphoma and large B-cell lymphoma. He had 6 rounds of R-CHOP and now is in remission with 2 years follow-up of bi-monthly Rituxan infusions. Do all cases like this one follow up with the Rituxan infusions?
Sorry, can you repeat the last piece? I didn't hear the last.
Do all cases like this one?
Do all cases, yeah. You mean the man is doing a maintenance therapy? Is that what?
Yes, doctor.
Yeah. So unfortunately, I'm not the most qualified person to answer this question because follicular lymphoma is not a disease that we see in children and or in adolescents and younger adults. I can tell you that maintenance therapy, whether it's rituximab or brentuximab or even nivolumab, have actually been introduced as a part of the initial therapy of lymphomas, and more in patients that actually experience a recurrence. For example, after an autologous stem cell transplant, then there is the option also doing a maintenance. For follicular lymphoma, I think it depends a little bit on for each patient, in the sense that it is possible, and obviously I don't know the details of the disease or of your family member who's being treated, but many choices or many adaptation of therapies are really related to the type of patients you're treating. So, for example, like you said, if it is a follicular lymphoma and a diffuse large B-cell lymphoma, which is already a little bit unusual to have these two distinct histologies in the same diagnosis, and also depending on the response that the patient had to R-CHOP, particularly if there is some residual disease, then the maintenance chemotherapy is absolutely a rational and reasonable disorder. So it may not be a standard, but may very likely be something that the physician has chosen particularly for your family member.
Thank you very much.
Sure.
We'll now take the next question. Please go ahead. Perhaps your line is on mute.
Oh, okay. Was this me? My question has to do with the targeted new therapies. Are there any known side effects that could occur, or could they make the cancer worse?
Could they make the count, you said?
Cancer. Could they make you?
Cancer,
could they actually
Yes,
make it worse? Yeah.
Cancer. So targeted therapies. Targeted therapies, we include both genetically, molecularly targeted therapies, as well as also immunotherapy is also a way of targeting the cancer because it's specific to specific protein. It's directed to specific proteins. So I don't know if you are talking in general about targeted therapy or if you have in mind a specific therapy with that targets a genetic defect. Now, generally, no, absolutely. In fact, we always consider that targeted therapy more, in a sense, safer. Why? Because chemotherapies are designed, specifically, they work by poisoning very, very basic mechanism that the cells use to double, to replicate. These basic mechanisms are the same for cancer cells and for normal cells. And that is why, for example, chemotherapies have a very small but existing risk of themselves causing cancers. Targeted therapies, because they target defects that are present only in the cancer cells, are not supposed to be harmful, create new cancer, or actually make the cancer more aggressive and more dangerous. So in general, the answer is no, they are not. They don't cause secondary cancer. They don't cause a worsening or a progression of a cancer. However, what can happen, and this is a property of cancer, is that the cancer has an addiction and a need and a desire to continue to live and grow. And so every time we put a block, we try to kill the cancer and block from growing, the cancer will try to find ways to escape that target, to escape that drug. So sometimes, that's exactly what happens when the cancer comes back, and that's why sometimes the cancer that comes back is more aggressive, because it's figured out a couple of ways of avoiding drugs. So to answer your question, targeted therapies are probably less toxic and are not don't cause a worsening of the disease. However, it is possible that a newly acquired mechanism of resistance could make the disease not respond to chemotherapy. And that is a risk and a phenomenon can happen with any therapy we use. And this is also the reason why, this is the reason, for example, depending on what the disease we're talking about, but many times, usually we, except for some exception, we try to use more than one drug to cure a cancer, because by using only one drug or two drugs, the risks of resistance and the cancer cell learning mechanisms to escape is much, much higher than if you put, or you alternate drugs, and if you use 3, 4, 5, 6 drugs, always kind of alternating.
Thank you, Dr. Sulis. I do apologize. I need to end the call here, as I know Dr. Sulis has another meeting to get to, and I want to respect her time. But we are so thankful for you being here with us today, and you are welcome to disconnect at any point. Thank you again. I'm sure everyone has learned something from you today. I myself just want to add, I know there was a couple questions sent to us ahead of time about finances and support.
Thank you very much. Sorry to interrupt. Thank you. Thank you for the invitation, and thank you to the audience. Thank you.
Thank you so much, Dr. Sulis. Yes, on financial questions, those of you who are looking for more financial resources, a couple of great places to start are Cancer Care and the Leukemia and Lymphoma Society. They both have very extensive financial support sections and can tell you about many resources, as well as Triage Cancer. It's a nonprofit legal organization for cancer patients that it can answer a lot of your insurance questions and things like that, as well as for support sources. First of all, National Bone Marrow Transplant Link. Like I said, we have a wonderful peer support program, as does the Leukemia and Lymphoma Society, and they have multiple online groups. And for the pediatric crowd, Alex's Lemonade Stand and the American Childhood Cancer Organization also have a multitude of supports available to assist you. But on that note, I want to thank everyone for joining us today. stay tuned for information. We have a multitude of programs for you this fall. Next week, we have a webinar on clinical trials that we'd love to have you join. So keep an eye out for emails, or you can go on our Facebook page or our website. And if anyone needs additional support, feel free to reach out to us at 1-800-LINK, which is LINK, BMT, and we are happy to give you more support. And then thank you again to our speakers, our sponsors, our link partners, and all of you for joining us today. Have a great day.